the question even as I'm speaking, that's okay. But generally, we'll save most of the questions until I'm done. I'm going to share my screen now. Hopefully, that'll be successful, and then we'll get started. Okay. So, how does that look? Can you see my screen now?
Yes.
Okay, great. Okay, so yeah, so maybe you should have your head examined, right? So that's the provocative title that I chose to try to get a little interest. So there are different ways to do that, getting your head examined. But as a neuropsychologist, one of the things that we do is we play games with people, right? We ask them questions. We look into things like attention and memory and language and so forth, in order to get a sense of what's going on. And what I want to talk to you about today is how we go about doing that, how that is, how different sorts of disease processes can impact that, and just give you an overview of how it all works. So I'll say, just one second. Yeah. So I'm from the Center of Excellence for Alzheimer's Disease at Stony Brook, and what I'm doing here today with you is sort of part of my job. It's to expand the knowledge of Alzheimer's disease and related dementias, to act as a resource for healthcare providers in Nassau and Suffolk. And we aim to improve access to screening, diagnosis, and treatment for patients and their families. And we're always here to help. You can give us a call or visit us on our website anytime. The other thing is, we have just recently begun to offer free cognitive screenings that I'm doing actually on Thursday afternoon. So if you're interested, give us a call, and be happy to arrange that. And I'll tell you a little more about that later. So, so as I mentioned, I'll be talking about what goes into a neuropsychological evaluation or a cognitive screening more generally, and how this sort of an evaluation can help us to distinguish between healthy, normal aging versus some sort of a disease process. And then also how it might help distinguish different types of disease processes, different sorts of dementias. So let's start by just talking about our basic terms. So dementia refers to a long-term and often gradual decrease in the ability to think and remember. And it becomes severe enough that it interferes with a person's ability to go on with their daily lives in terms of their occupational activities or their social activities, or what we refer to as instrumental activities of daily living. I'll tell you a little bit more about that in a minute. Mild cognitive impairment, these folks are having some difficulties with thinking and remembering, but it's not severe enough that it's impacting their ability to live their daily lives. And each of these terms, dementia and mild cognitive impairment, can be caused by a variety of brain diseases, many different ones. And they usually affect people who are older, about 65 years of age. So some of these activities of daily living that tend to be impacted early on include things like, traveling independently by driving or public transportation, being able to handle their own medications, a decrease in the ability to handle finances, housekeeping, food preparation, shopping, ability to use a telephone. These are all sorts of things that are examined when we try to assess whether a person has a problem with their daily activities. And interestingly enough, in these are questions from one of our actual scales. Women have to score higher. Men don't have to score as high as women on this, right? The food preparation, the housekeeping, they can be normal. Men can be normal without having to do those sorts of things. Unfortunately, maybe things are changing now, but the way they're scored, even at this point, men get a little break. So, as I mentioned, dementia is this general term, and so is MCI. these kinds of changes in a person's ability to think and their ability to go on with their daily lives can be affected by many different diseases. So Alzheimer's disease is one of them. Lewy body dementia is another, vascular dementia, frontotemporal dementia. These are all different types of brain changes that take place that can lead to these sorts of clinical symptoms. So vascular dementia refers to the impact of small strokes or larger strokes that impact thinking and memory. So dementia in general is a global problem as well as a local problem. Close to 50 million people are affected by it throughout the world. Right here on Long Island, it's over 55,000. And the numbers keep climbing as the population ages. In general, the proportion of older folks increase. Around the world, we spend close to $1 trillion every single year treating this set of diseases. And in the United States, we spend about $250 billion because, you know, healthcare costs here in the United States are so much higher than everywhere else. And that money doesn't include the $250,000 here in the United States, $250 billion spent here in the United States doesn't include all of the free care that people provide to their loved ones, you know, their spouses or their parents or their children, or, you know, that's another $250 billion in terms of reduced time at work and things like that. So it's a huge problem. It's been called the greatest global healthcare challenge of the 21st century. There are many different reasons why an adult who was doing okay experiences a decline in cognition. A number of these things can be reversible, and that's one of the reasons it's important to have have an evaluation, because a number of these things can be treated pretty quickly. Things like vitamin B12 deficiency, things like infections, urinary tract infections can affect cognition, hypothyroidism, dehydration, and medication side effects as well. There are medications that have side effects that reduce ability to learn and remember, to pay attention, or to remain awake. And all of that can interfere with cognition. And because as we get older, we tend to be on more and more medications, it's important to have, you know, one source, one healthcare provider, one physician who's looking over all your medicines and making sure that they're working in concert and that you're not experiencing any side effects that they can alleviate. There are a number of diseases, a number of disorders that we can't reverse. We can treat some of the clinical symptoms. We can improve quality of life for the person as well as family, but we can't cure them at this point. And that includes things like Alzheimer's and Lewy body dementia and frontotemporal dementia. So
excuse me, could I just ask you to speak up a little bit?
Sure.
A little louder. Thank you so much.
Absolutely. In fact, I'll put on some headphones. I didn't realize that I wasn't speaking loudly enough. Give me a second. This should help. Okay. Does that improve things? Can you hear me okay?
Yeah.
Yes,
Okay.
that's perfect.
Yes.
Thank you.
Yes.
Great. Okay. All right. Before we talk about different sorts of disorders and what can happen in them, I want to tell you a little bit about what brains do. All right. And I'm going to give you a hint right here. This is your hint. All right. And what that's supposed to lead you to think is that brains are trying to predict the future. All right. They're like our
Crystal ball.
Thank you very much. We'll talk about word finding problems a little bit later. Thank you. Which is normal, by the way, or at least to some degree. Yes, it's like our crystal ball. We use our brains like our crystal balls. We're trying to predict the future. And a lot of the models of the brain that are the most popular and that are really gaining traction treat our brains as this crystal ball, as a prediction machine. Okay. So let's say you and your brain were sitting down, have a cup of coffee and maybe read a book, and all of a sudden you heard this loud noise. Okay. Well, you've got to figure out, well, what is that? What is that noise? And you always have two sources of information when you're making that decision, when you're trying to figure that out. You've got the information itself, that noise itself, but you also have your prior knowledge, right? And all of that goes into your interpretation. So if you know that it's windy outside and you've got trees that are close to the house and they kind of bang up against the house or the windows, you might say, oh, that's just the trees. It's windy outside. But if in your neighborhood there was a string of break-ins, right, then you might treat that same noise in a different way. You may interpret it in a different way and act in a different way, right? In terms of securing your home or whatever it is that you need to do, right? And so our brains are always trying to make those predictions, and we update them as quickly as we can. So if you look out the window and you go, oh, it was just that tree, right? That changes your interpretation. That, alters what you might do. But there's always a level of uncertainty, and we're always just trying to figure things out as best we can. And so our brains can be thought of as doing two things. First, what's important, we call that salience. What is important to us? What is it around our environment, or what is it that I'm planning to do that can make me happy, or what is making me mad or sad or excited? What is new, right? What is drawing my attention? And then what is it that I want to do about it, right? If I have a problem, how am I going to try to solve that? If there's something out there that I want, how do I go about getting it, right? How do I plan? How do I problem solve? How do I figure a way to do it? And what happens is that uh, well, we learn about what's going on in the outside world through our major senses, right? So our this is a little cartoon of the brain in this sketch here, and I don't know if you can see my little arrow kind of surrounding that cartoon of the brain, but you can see different colors. So in the red is vision, which is sort of in the back of the head in the occipital lobe. Hearing is sort of on the side near where your ears are in the temporal lobe, and touch, somatosensation, is just here, kind of running down the side, the middle of your head in the parietal lobe, and motor activity is just a little bit in front of that in the frontal lobe. And what you can see is that it's certainly important that we get that information in and that we have some ability to act, but most of the brain is not colored in those different colors, right? Most of it is gray. That's all the rest of the brain, the rest of the cortex, the sort of the major sort of controls our higher cognitive functions. That's devoted to interpreting what's going on and figuring out how to deal with it, all right? So a lot of our brain is devoted to that crystal ball activity. And so that's what I just kind of mentioned. So all of this is sort of a moving target. We come into the world not knowing very much, right? As babies, everything is kind of new for us, or it might be a little scary, right? But over time, it kind of becomes redundant. Oh, I've seen this before. Yeah, well, it's cold again, or it's warm again, or it's whatever it is, right? So, the blessing of getting a little older is that we develop, hopefully, a little wisdom, a little expertise, a little practice in what we have been exposed to. But the curse on the other side is that it's a little less fresh for us. It's a little less novel and new for us, and it's also a little mm, we are constrained to a degree by all the things we already know and already know how to do, and it's a little harder for us to be flexible. So that's what happens normally as we age. And and this quote that I provide from Monty Python and the Holy Grail is what we've done may not be perfect, but it's good enough. And what we mean by good enough is not dead yet. I'm not dead yet, right? We haven't made a mistake that's that severe. Okay. But over time, we do become these creatures of habit. So that 40% of our daily routine of making the coffee, of driving to work, or saying hello to someone that we meet on the street. All of that is kind of automatic. You might find yourself driving in a car, arriving at someplace and thinking, I don't really remember driving here. I know I got here. I know you started at my house, but that whole ride, I was on automatic pilot. And you can do that, right? Something as difficult initially, right, as it was to learn how to drive that car, you learned how to do that, and it became sort of automatic. And so much of our life becomes that way. But guess what? Over the past year, we have become aware of our habits in a way that we might not have wanted to, but it's a lesson that maybe is important. We've dealt with this coronavirus, which has interfered with all of our daily routines, right? Has made it difficult for us to, figure out what's important, how we should be living our lives, our social interactions, our jobs, our, everything, right? Um, and so it's been destabilizing, right? And we have learned that things we didn't know were important are important again, right? So toilet paper, right? So toilet paper for a few months there, that was really, really important, right? Because we couldn't find it. Yeah. And who, a year ago was aware of what this circle with these red dots on it was? Nobody. And who was thinking about masks? You know, so we've had to make a lot of adjustments, and we're sort of in the process of developing this sort of new normal now, right? And it's a changing, moving target, but it does show us how much we've taken for granted because it was habitual. So as we get older, there are certain aspects of our thinking that do decline. All right. So the speed with which we process new information. Let me just explain this graph to you first. So you see a lot of the greens and blue and gray lines kind of going down as you go along. And these other red and orange lines kind of are stable. Well, this shows what happens as we get older. Okay, so on the left side, on the bottom, these are 20-year-olds, and over on the extreme right, we have 80-year-olds. And as we get older, we decline in the speed with which we can process information. We decline in what we call working memory, or ability to attend to new stuff going on in the world and hold on to it in order to think about it. We decline in our ability to learn new information. These blues are what we call long-term memory, but really it is developing new long-term memories, and through tests like learning a list of words, for instance. I might ask you to learn a list of words, and it's easier for little kids or teenagers, or at least young adults, to do that than it is for us as we get older. Our ability to recall those words is a little harder, and we can still generally, with normal aging, recognize the words we saw. We just can't call them up as quickly. Okay. So, but the one thing that does remain is our knowledge of the world, right? That's what we were talking about. That's our experience. That's our wisdom, our vocabulary, our knowledge of facts that we've known for a long time. That stuff sticks around, normal aging, and is fairly stable. So by the time someone as an adult comes to see me, particularly, an older adult who is concerned about maybe there being some changes, they've gone through a lot of life, and I need to understand sort of what their experience has been. Where have they worked? What kind of education have they had? What language did they learn to begin with? What kind of cultural things might they have had? What are their interests? All of those things tell you who that person was to begin with, because what we're looking at now, when we're looking at the possibility of mild cognitive impairment or some form of dementia, is a decline from where they were before. So different people have come into the world and lived through the world with different strengths and weaknesses, and we're trying to understand where they were to begin with in order to see where they are now. So there are some screening tests. So this is a set of 8 questions. It's called the AD8. And it's something that primary care physicians might use to kind of quickly ask a person or ask the spouse of a person whether there have been any changes, right? So notice that for each of these questions, the answer is yes, there's a change, or no, there's no change, because everybody has those strengths and weaknesses to begin with. So you're looking for things like problems with judgment. Maybe that person didn't have great judgment to begin with, but it's declined since, right? So you're looking at that change. A common thing that can happen in some forms of dementia, including Alzheimer's, is that the person repeats the same things over again, right? They may do that not because they're trying to annoy you, right? But because they don't remember that they said that before, right? Or maybe they had this question and they remembered that you might have given them an answer. They just can't remember what the answer was, right? And so that can be frustrating to the person. It can be frustrating for the person who's interacting with them as well. But it is the sort of the disease talking. It's not the person when this happens. We all may occasionally forget the day, oh, is it Thursday or Friday, especially during COVID now, these days, everything is sort of blurs day, right? The days blur together. But if we forget that it's winter versus summer, that's far more severe. That means that person's brain hasn't been keeping track of, large scale changes that have occurred and been maintained over a period of months, right? Um, um, Someone who, occasionally we misplace objects and stuff, but if you find objects in weird places, like your glasses end up in the refrigerator, these are the sorts of things that would lead you to want to get evaluated further. This is just a screening test. Okay. So one of so what I showed you before was that AD8 questionnaire, but you can also undergo a short screening set of tests that would look at things like whether the person is oriented, whether they know the day and the date, whether they know where they are and who they're with, whether they can pay attention, learn new information and hold on to it, whether they can deal with these executive functions. That has to do with knowing what to do in those novel situations where you have to solve a problem, where you don't have the answer automatically. That's when these executive functions come into play. A lot of what we process comes in through vision, and so visual spatial processing is important, and our language is also crucial for our communication and for our interaction with the world. And so we would examine that. And all of that goes into this one test called the MOCA. It's a brief test. It's stands for the Montreal Cognitive Assessment. This is actually the test that our former president took. And President Trump mentioned that he had taken this test, this is the one that he took. And he's the one who said that he, heard these 5 words: person, man, woman, camera, television. But those aren't really the words, so don't try to memorize those. So let's look at some of the things that go into the ability to think and to learn, and these different aspects of cognition, just a little bit more, in a little bit more depth. Okay. We can talk about simple attention, or what we call working memory, as the ability to hold on to a certain amount of information. We get overloaded by too much information, and we can only sort of handle a certain amount. And so one of the ways we get at that is maybe asking people to repeat a series of words for us, okay, in the same order that we might say them. So I might say moose, peanut, sun, envelope, and then just say, repeat those for me. And the person should try to do that in the order that they were presented. And you can do that with, 4 words. That's not so bad. But if I were to give you 8 words, that would be really hard, right? If I were to give you 6 letters, that might be a little tough, right? But what if it was this: FBI, CIA, right? Maybe that's hard, but maybe it's a little bit easier if I said FBI and CIA, right? Because those are 2 things, those are 2 abbreviations you already know, or you probably already know. And if you know them, you can chunk them together. So you're not having to remember 6 pieces of information. You're only required to understand and remember those 2 pieces of information. That's called chunking. So that's like a shortcut, and people will use that and take advantage of that and figure out their own ways of organizing information in various ways to give them an advantage, a heads up. And so it's hard to try to design these tests, and it's hard to do these sorts of evaluations, but you need to know that people are just trying to solve problems and figure out the world the best they can, and they're going to use whatever tricks they can. So there are other aspects of attention, though, that might be more complicated, that are, that involve more complex processing of the information. So I might give you those same 4 words: moose, peanut, sun, and envelope, but tell you, please tell me those words in order in terms of the size of the object, from the smallest to the largest, right? Then you'd have to hold on to those 4 pieces of information, and you'd have to say, okay, what's the smallest one? Oh, envelope. All right. Then we come to, excuse me, peanut, then envelope, then moose, and then sun, right? Yeah. And people make mistakes. Or you might do it based on the length of the word, right? And then the order would be completely different, right? But so attention and working memory go into this more complex thing, where you're taking the information, that limited amount of information you have, and reorganizing, you're manipulating it. You might also ask people to do a task where they have to sustain their attention over a long period of time, right? So I might say, I'm going to tell you a bunch of different animals now, and whenever I say a moose, I want you to tap your hand on the table. All right. And so that would allow us to understand if you were able to sustain your attention on that one thing over a period of time. So much of our daily lives, though, involves us being bombarded by lots of stuff, and our attention is divided. We've got these, cell phones. We're distracted by what's on the TV, or, by what people are doing. There's a phenomenon called the cocktail party phenomenon, where you've been to a party and you're talking with someone, or actually you're listening to someone who's not very exciting, right? They're a little boring, and behind you is a really interesting conversation, right? And you're trying to nod at the right time so that the person you're talking to you doesn't realize, but you're trying to pay attention to two things. Your attention is divided. We call that the cocktail party phenomenon. And we have some neuropsychological tests to look at that as well. So these are all different aspects of attention, right? Because what we pay attention to is very selective, right? There's this funnel, right, that goes into our brain. We have a zillion different things going on in the world, and we only pay attention to a limited amount, all right? And attention is how we do that. I mentioned executive functions as when we generally when we have to think on our feet, when we can't just go in automatic pilot, right? So people who are literate in English, who can read English, can easily read the words blue, red, and green here, right? And can easily tell you the color of each of these words on the top line, blue, red, and green. But if I were to ask you instead to name the color of the ink for each of the words below, you would go a little slower, right? Because this word blue here on the bottom left is written in red ink. And in order to inhibit reading, it's hard, and you have to use what we call executive functions, that you're inhibiting the automatic response, because good readers will automatically read words rather than name the color of the ink that they're in. So that's one example of an executive function test that we might give, a kind of a game that we would do. We would see how much slower a person became when they had to do that, tell the color of the ink on the second line than on the first line. A lot of the information we get in the world comes through I should say, let me just go back to attention and executive functions that we just spoke about. Different forms of dementia affect these areas differently. And so people with vascular dementia, the most common form of vascular dementia are what are referred to as very tiny strokes. They're white matter hyperintensities that appear in neuroimaging, and we all kind of develop them as we get a little older. But people with dementia tend to have even more. And what they do is they interfere with the connections between different areas of the brain. And one of the things that it does is slows down our ability to process information and makes it less efficient. So it's harder for us to pay attention, and it's harder for us to sustain our attention, and it's harder for us to deal with situations where our attention is divided, and harder for us to deal with novel situations where we have to change our preferred ways of behaving. Attention can also kind of change over the course of a day, or even over the course of hours, in people who have something called Lewy body dementia. They may be sort of on top of their game at one moment in the day, but then change over time. So these are different kind of clinical symptoms that tend to be associated with different forms of dementia. Visual processing. So much of the information we get comes through our visual sensory system, and we can look at that in a variety of ways. We might look at it in a simple way, as in terms of just judging the angle of lines with a test called judgment of line orientation. So here you're just supposed to provide the number of the lines below, in that semicircle below, that are at the same angle as the ones above. And so that this top one, this one here going up and down, corresponds to the number 6, right? And the other one you just have to figure out as well. So that is sort of a pure basic perceptual task. But there are other tasks where you have to try to understand what it is that you're seeing. And so this task here, this visual perception task, it's like a puzzle, except you don't get to put together the pieces. You're expected to try to figure it out just by putting it together kind of in your head. And so this is a flamingo, right? But in order to see that, you have to organize those three pieces on your own. And sometimes in different forms of dementia, the problem isn't that the person can't see clearly, it's that they don't understand what it is that they see. So someone with Alzheimer's disease might not realize, when they walk past a mirror, that the image that they see is the image of themselves, the reflection of themselves. They may think that they've seen someone else, right? Or they may see someone and mistake them for someone else. So they may think that someone is their daughter, or when it's not. There are also tests that look at the way that our people perform visual motor construction, which involves visual and motor activities at the same time, where they might have to copy a complicated figure like the one there on the right. And that brings up an important point, in that a lot of the times when people are doing a task for us, it's a complicated thing, and they could make a mistake that could make an error for a variety of reasons. So we're always trying to figure out why they might not be able to do it. So if a person has problems with the drawing aspect, that may not reflect on their ability to see, but it may reflect on their ability to do fine motor movements. And so we're always trying to tease apart where the problem might be if a person is showing some sort of a weakness. So when you're looking at motor processes, you can look at a variety of things. You can look at the way a person walks, their gait. You can look at their fine motor movements, like their ability to, tap their fingers quickly, or put pegs into holes quickly. You might ask them to do different sorts of commands, like, touch your nose or touch your left elbow. But again, that sort of a task, following commands, depends on you being able to comprehend language, right? And so if the person is not comprehending language, that's another reason why they might have had problems with that, with following commands, right? Not that they can't form the movements, but that they don't understand what it is you wanted them to do, right? And there are different ways you can overcome that issue. You can sort of model the behavior and see if they can just do what you do. Instead of do what you say, they do what you do, right? There are other ways to test language, not just the person's comprehension of language, but their ability to repeat it. So time flies like an arrow, fruit flies like a banana. So can the person repeat that sentence to you? Okay. You may also look at the person's ability to express themselves. So you may want to show them some drawings of things and ask them to name what those objects are. Can they recognize a giraffe? Can they recognize a pair of scissors? And tell you what those words are. Can they come up with words on their own? Maybe words that begin with a certain letter, or words that belong to a certain category. Can you tell me all the vegetables you can think of in a minute? That might be a way of getting at the person's ability to express themselves. And then in conversation, conversations are kind of at a higher level usually. And we can look and see how the person is able to express themselves, whether they're halting, whether their ability to express the words reflects some problem with their motor movements, their orobuccal movements. So these are all different aspects of language that can be impacted, and there are certain forms of dementia that specifically target language. Primary progressive aphasias affect language specifically, and there are other forms of dementia that might affect some specific aspect of language. So in Alzheimer's disease, a person might specifically have more problems telling you words that belong to a certain category. That might be more difficult for them than it used to be. So you're looking for these different clues in the way that a person presents and performs these different sorts of tasks. Then there are other tests that look at different aspects of what we call abstract reasoning. So you might present them with 3 words, apple, orange, and insect, and say, which one of those 3 words doesn't fit, right? In order for them to do that, they have to recognize that, you know, apples and oranges are both fruits and an insect is not. They're all living, where they come from living things, but they're only insect is the one that stands out as an animal, right? Or you might show them 3 shapes and ask them, well, which one of these doesn't fit, right? And here it would be the circle, because that's got rounded edges. All the other ones just have straight lines, right? But in order to understand that, you have to have an appreciation of this abstract concept of, of the straight lines versus curved lines. So these are all different kinds of games that we might play with folks who come in for testing. It's also important to examine the person's emotional state and the person's ability to evaluate and perceive emotions and express emotions as well. So this is just a brief scale that might point to the possibility of depression. If a person has lost interest or pleasure in doing things that they normally liked and enjoyed, if the person has been feeling down, depressed, or hopeless, and this has been going on for a couple of weeks, all right, that might be an indication that the person might be depressed, and that can affect a person's cognition as well. Remember when I was talking about how the brain tries to process what is important, right? Well, those things kind of highly depend on our emotional reaction to things. And so if our emotions are being are not regulated normally, that can affect what we consider important or consider scary or consider pleasant. And so all of that can be impacted by different forms of dementia as well. There are certain forms of frontotemporal dementia that specifically impact personality and may make a person more apathetic, may make a person more impulsive on the other hand, but can affect their what we call comportment, or the way that they present themselves. And sometimes when people are experiencing dementia, it is caused by, it leads to an exaggeration of the way that the person had always been, you know. Dad's always been like that, but now he's even more like that, right? But other times, the disease process can lead to a complete change in a person's personality. I just wanted to mention that the relationship of depression to different forms of dementia is kind of complicated. It's not that a person, it is entirely possible for someone to be both depressed and have a dementia at the same time. They're not mutually exclusive. But treating the depression can often improve cognition, because when we're feeling depressed, it's harder for us to pay attention. It's harder for us to put forth effort in what we're doing and to learn new things. And so treating the depression can be of help. So as I was going along, I was mentioning different ways in which these different disease processes could impact the way that we think, but I'll just review a little bit with you. So in Alzheimer's disease, often the most common early symptom is that a person has trouble holding on to the new information that they learned. They may be able to repeat those words for you initially, but if you wait a few minutes, it's hard for them to come up with those words and even to recognize those words. They may have problems with naming of objects that they've seen that are drawn. They may have problems telling you words that belong to a certain category. Those are all kind of typical early signs in Alzheimer's disease. There are forms of Alzheimer's disease where, and Alzheimer's disease is characterized by damage to the brain of specific type, amyloid changes and tau tangles. And sometimes that kind of pathological change to the brain is not initially associated with these symptoms that I mentioned, but often and usually it is. In Lewy bodies or Parkinson's dementia, those are both similar to one another, it is where we see attention varying over time. We see problems with executive functions. We see problems with visual perception. Sometimes these folks will experience hallucinations, often visual hallucinations. I had one woman who could out of her peripheral vision see a black cloaked figure that looked like an opera singer, and sometimes they even hear that opera singer. She knew that wasn't a real person, but still, if you asked her, she would say, yeah, I do see that person, and that can sometimes be accompany a Parkinson's dementia. Sometimes sleep is impacted in Parkinson's disease, and in Lewy body dementia, sometimes sleep is affected. And so normally when we are asleep, and especially when we are dreaming, our body is basically paralyzed. We don't move during the dream stage of sleep. But in Parkinson's, sometimes the person is moving. The spouse will notice the person is moving a lot more than they used to be, and that can be an early sign. In frontotemporal dementias, they will often have problems with motor actions and these executive functions, or there may be personality changes. Sometimes there are language changes. And in the vascular dementia, I mentioned that there's sort of this inefficiency, a slowed processing, problems with expressing oneself, slowed information processing, things like that. So these are all sort of the ways in which the pattern of weakness that a person shows might be linked to different forms of dementia.
Someone has a question. Could we just ask it now?
Absolutely, and I'm just about done, actually. I was going to just mention that caregivers, often it will experience stress and problems with the burden of caregiving, and so it's important to look at that as well. But basically, that's it. So I'm happy to answer any questions you have.
I was going to ask, you mentioned with the Lewy bodies, the hallucinations. My
Yes.
mom's got that now. She's in a nursing home. She's going to be 94 next week. So she's got visual hallucinations, having full-on conversations with Donald Trump and Judge Judy, and also auditory hallucinations. She's hearing music, but her initial, the way she presented, it wasn't obvious it was dementia. It wasn't really a memory. It was always more of a paranoia. I hear people in my closet, they're coming in at night, they're taking things, that I was stealing things, the aides are stealing things. So it's been sort of unusual. I'm thinking it's more of a Lewy bodies. I don't know if there's a paranoia piece to any of this.
There can be a paranoia piece to, and it's not just the Lewy body dementia that can accompany. It can be sometimes it can kind of come and go during the progression of the dementia, but it can often be there. I mean, one of the ways to try to understand that is the person's trying to figure out kind of what's going on, right? So if a person let's say maybe with the Lewy body dementia is having problems with their attention, and so they're kind of tuned out and they don't recall something happening, right? So they don't recall maybe putting something down in a particular place, and then they're looking for it and they can't find it. They might think, well, maybe that's because somebody took it, right? Somebody did that, so the person is trying, like we all are, to figure out what's going on and how to deal with it. But sometimes it leads them to the wrong conclusion. And what can also happen in different forms of dementia is their person's ability to sort of regulate their emotions may be impacted.
She's been very angry. Yes.
And so, whereas she might have been just mildly ticked off before, now it's harder for her to kind of inhibit that anger or
Right.
emotional response.
And now it's like, you're not the real Monica when I call, you're the fake Monica. A lot of
Yeah.
it seems to be progressing, and new things keep coming up.
Right. Yeah. And a lot of times, those can be some of the more difficult symptoms, it's not so much the memory problem, but the sort of the anger or the wandering or the sort of these other symptoms that kind of are get in the way, and that can worry families the most. And
Right.
there are some medicines that can help. So
They put her on Seroquel.
yeah. So that is one of the medicines. I don't prescribe the medicines myself. I'm a PhD. I'm not an MD. But there are some medicines that are prescribed. So if you wanted to consult with any of our physicians here at Stony Brook, you could call us at that number.
Okay, terrific. Thank you.
Sure.
I have a question.
Absolutely.
So in late stage, my husband is in later stage now, Alzheimer's. What types of things, and he has obviously trouble speaking. And I have seen a decline of late. What is he occasionally has becomes lethargic, but then he's okay if he goes out for a walk. I just want to know if that's all typical, also closing the eyes, which he's been doing more lately. Sometimes he's fine and good spirits and, walks and plays ping pong and does whatever he does. But other times he's just not quite tuned in.
Yeah.
And that's all, I assume that's all very normal. I guess I want to know what's next. What does one look for?
Right. So, yeah, people do, progress through different stages. Sometimes a person can be lethargic because their sleep pattern is off. That can sometimes occur. And so their sleep-wake cycle is off, or they're napping more during the day and not sleeping as much at
So
night.
one can expect that. His sleep
Yeah.
pattern is fine.
Okay, good.
But that's later stage, they do sleep more, is that it?
It can be the case. There may be less that is of interest to them, and so they may have trouble sort of remaining attentive. It does in the early stages, these problems with recent memory and some language, but as the disease progresses, it does interfere more and more with even more basic activities of daily living, as well as just basic, basic activities. Towards the very end, there can be problems with swallowing, with breathing. It does progress at the very end in that way.
Okay, and one other question. Are you familiar with this study? There's apparently on, I think, Prime, there is a documentary on mushrooms and how they're studying the value of mushrooms for the chemical part that's in mushrooms for people with dementia and other kinds of diseases.
Yeah. So for many years, that kind of research was kind of taboo. But it's become easier to get that kind of research done. They're still in the early stages in a lot of those areas, and in terms of dementia, I don't think there's any strong evidence that it can be of benefit at all. There are, they are beginning to look at some of this in terms of treating depression, in terms of treating traumatic people with PTSD. And so they're beginning to develop some evidence to hopefully in the future, find some novel treatments for those diseases. But as far as dementia, I don't know of any good data. I'm not familiar with that Prime, Amazon Prime documentary though, and I'll check that out. Thank you for pointing that out.
There's a question in the chat from Lisa.
Yeah.
Lisa, do you want me to read your question or do you
Yeah.
want to ask it?
I could ask. Is
Okay, go
this
ahead.
related to when you were talking about Lewy body and Parkinson's? So my mother, I honestly don't really know what Lewy body is. I've read about it, but I don't quite understand it. My mother has Parkinson's disease and dementia, but she often sees babies and cats that aren't there. But how do I know that this isn't a side effect of the medication? Or how do I know that it's the illness? Because I really think the medications sometimes are more detrimental than the illness itself.
Well, so I don't prescribe the medicines, but I can, and so I would always defer to your physician, or if you're not happy with your physician, to finding another physician. But that said, visual hallucinations are very common in this disorder, with or without medication. And it's probably difficult to to tease those things apart, but those sorts of symptoms are common, because of the disease. If you look at the brain, and the way the brain is activated, you would see in the back of the head, in that occipital lobe where visual processing is occurring, you see that in Lewy body dementia and in Parkinson's disease, and I'll talk about the relationship in a second, that there is a decline in activity in that area. And so that probably underlies some of the visual problems. And that is there regardless of whether the person has been on medicine or not.
Okay.
In terms of the Lewy body versus Parkinson's, in part it's due to when the symptoms arise. They're both associated with a particular type of protein problem in the brain, an abnormal protein that is created in the brain that leads to what are called these Lewy bodies. So that's the abnormal change that takes place in the brain in both Lewy body and Parkinson's. In Lewy body dementia, usually it is the cognitive problems, the problems with attention and visual spatial processing that happen early on in the disease. And in Parkinson's, it's more often the motor problems with the tremor and things like that. But as the disease progresses, they tend to merge, and there are more symptoms of both kinds as the person progresses. That's not in everybody, but that's the general thing.
Okay. I have one other question.
Sure.
You mentioned something about having one doctor that manages, here, I'll show my face, that manages the medications. So her neurologist recommended that I find a psychiatrist to manage the Seroquel. And
Yeah.
So they're not managing, one doctor isn't managing the medications, two are. So one's dealing with the Seroquel, the other one's dealing with the carbidopa levodopa, and the pardon me, I don't know how to pronounce it, rivastigmine patch that she wears on the shoulder. So I have two doctors who don't talk to each other all the time, but
Right.
she does see them. She does see each of them.
So one is a neurologist and one is a psychiatrist?
Right.
And are they aware of the medications that the other person is
Well,
providing? They both have a full list of the medicines.
Right. So the psychiatrist has spoken to the neurologist. I don't know how frequently they speak.
Right.
No.
Yeah. It sounds like, both of these, physicians with those two backgrounds are specialists. and both kind of treat this kind of disorder in general. And so they should both be generally familiar with the benefits and and possible issues surrounding different medications, such as what you're talking about.
Because
it-
I said to the psychiatrist, just what I asked here, how do I know that the Seroquel isn't causing more hallucinations for my mother? And she kind of just brushed me off and didn't answer my question.
Yeah, you know, it is probably difficult for anybody to say for certain in any given individual exactly what is happening, right?
Mhm.
We can say what studies that have looked at this have found in the past, right? And so before these medicines were around, there were people with these kinds of with these diseases, and they showed, visual hallucinations. So it's a common sort of a symptom associated with the change, with this disease. You can also look at people on and off Seroquel, and there are different ways to try to answer the question, is what I'm saying.
Okay.
But
Okay.
but nobody's going to be able to say with 100% certainty.
Okay. Okay. Thank you.
Sure.
I'm
I have
I'm
a
sorry,
question.
cannot talk.
Diane?
Lamictal. So now they took her off the Lamictal and put her on the Seroquel.
I'm sorry, I didn't catch all of that. Could you repeat that?
I think it's frozen. Yeah, my mom was put on Lamictal for anger, and now they took her off it slowly because they thought maybe that's causing the hallucinations, and they put her on the Seroquel, which she may or may not need, but it was very sudden how it got bad all of a sudden. And then they found she also has a UTI, so I don't know how they know what's causing
Right.
what.
Yeah, the UTIs can really interfere greatly with a person's activities. I- it it is psychiatrists, the physicians who are prescribing these medications are doing the best that they can, but it's not an easy thing. It's a complicated and often individual sort of thing. And
And
so
trial and error almost.
yeah, there is some of that.
May I ask
Diane?
my question?
Yeah, please.
Sure.
Hi. I was wondering how cut and dry all of the characteristics of your various types of dementia are. In other
Not that
words,
cut and dry.
can you pick and, could you have one from column A and one from column B? And which makes it more difficult to even diagnose the type of dementia. I see little bits and pieces of my husband aside from the Alzheimer's, in the other three, in terms of movements in bed. Well, he's never been diagnosed with Parkinson's, and I can't give you any other specific, but I'm just saying that I would imagine it must be very difficult to place someone in a particular category if they are not exhibiting, if they're exhibiting symptoms of the various categories.
Yes. So, an evaluation, a neuropsychological evaluation, is just one piece of coming up with a diagnosis, right? There are brain imaging techniques that are used. There are blood tests. There's careful history that's taken. So there are a lot of different factors that come into play, and oftentimes it's not cut and dry. my testing is not cut and dry. One of the things to keep in mind, though, about what we do in a neuropsychological evaluation, yes, it's important for diagnosis, but it's also important for sort of understanding, well, what is cognitively what's going on with this person, emotionally what's going on with this person, because it may not be entirely clear. A lot of people, for instance, will come in and say, I have problems with my memory. And it's not their memory, it may be their attention. They're having trouble paying attention. And so they've never learned the information. They're not going to be able to tell you that information after 10 minutes because they didn't know it after 1 minute, you know? And so being able to understand for yourself and or for your spouse exactly what's going on is important. And those are the things that are sort of impacting their daily lives. So the diagnosis is part of it, and it's not clear cut. People screw up on tests for many different reasons. And we do our best to sort of put that puzzle together, that flamingo, we do that with our neuropsych testing as well, right? We're trying to figure out how it all fits together.
Yeah. Thank you.
You're welcome. I want to mention one other thing, if I could, that we're doing a lot of research at Stony Brook. There's studies that are looking at different neurotransmitters and trying to treat the disorder. So there's a study going to be looking at women with Alzheimer's disease and the effects of hormones, of estrogen on their cognition. There are people who are looking at changes in mood, in older folks. There are people who are looking at World Trade Center responders who may be experiencing some symptoms. There are people who are looking at those who are caregivers for those with Alzheimer's and looking at them because, we've had it in my family. So, I'm talking from experience as well. It's a real burden. It's a stressful one, and it can impact the person's immune function and health as a caregiver. And so there's somebody who's doing a study specifically looking at caregivers. And, as I mentioned, we're doing free cognitive screening. So if you or anybody would like, a quick one, you don't have to take the results to your physician, but, we would, you do with it whatever you want, but we are doing them. And
Is that a virtual screening? Could that be done via Zoom?
We generally are, right now we're doing them all in person. We just started recently. We may start doing some virtually as well, but we haven't started to do that yet. But if you were interested, or if anybody you knew was interested, you could call, and if we got a real pull for that, we might be able to make that happen as well. But that number at the bottom with Stephanie Roncone is the number to call for that sort of thing. Any other questions? I'd be happy to answer. All right, well, anything?
Ask if there is a genetic component.
Sure. Yeah. So for the different diseases, there are different, genetic contributions. For Alzheimer's, I'm sorry.
I think someone just joined us over the phone.
Okay. I was going to say for Alzheimer's disease, it depends in part on what form of the disease you have. There is what is called a early onset form that hits people who are 60 and below. And in that form, there is a fairly strong genetic component. But in the normal Alzheimer's, that affects the vast majority of people who do develop the disease, there's a genetic component, but it's a lot weaker. There's no sure thing just because your parent has it. And for most of the common forms of dementias, there's some genetic component, but it's not, by no means a sure thing.
Can I just mention something that I've uncovered, and I'm sure you're very familiar with this, and for anybody else out there listening. Ambien which many caregivers take for sleep, does cause memory problems. And I can tell you that firsthand. And also Benadryl. And so some people are on Benadryl and think it's very mild, but there's definitely long-term issues with taking Benadryl on a regular basis. So.
Yeah, no, thank you for bringing that up. I think that taking any of these, Ambien or Benadryl over a long term is something you should do under careful supervision from your physician, and letting them know what's going on with you, because those are common side effects, Ambien especially.
This is Marv. I've joined you by phone also. I'm watching on my computer, but it has no microphone. I have a question, please.
Sure.
The verbal memory screening tests here, and in my experience too, present only nouns. Why? Why not include, for example, brown, cooking, rapid, thorough as test words?
There are, what I presented to you today were just sort of example words. There are common neuropsychological tests that have lists of words that will include things like colors and verbs and things like that. Nouns do tend to predominate. The ability to remember things can vary for a number of reasons, and words that are more concrete, that is more easily visualized, are easier to remember. And so sometimes tests are designed to not be so difficult, right? Or at least to, with words that are too abstract or too unfamiliar to everyone. And so sort of the choice of words is an important one. But what you hope to do when you're doing a test like this is to give it to a lot of people and see how they do. A lot of people in a certain age group, for instance, and who have a certain level of education and a certain background, and see how they do. And that establishes what we call our normative sample. And then you look at a given individual and you see whether they're doing better or worse. But it is true that, words like verbs may be underrepresented in these lists. And there are people who study language in more depth that do, look at all these things, but it's not as much in sort of your typical tests that you would be administered.
Related question, please. Do you find a difference, people with who are fluent in multiple languages, do they have a different level, a different kind of skill, and would need to be evaluated in a different way for these tests?
It does make things a little bit more complicated. You generally would like to have someone who grew up speaking English and knows only English. That is the simplest person to do the testing with. Someone who learned English as a second language, especially after they were after puberty or after their teens, they will often not develop complete fluency. Those are the folks who will often have an accent, right? Because there are critical periods in which a person learns to perceive sounds within a language. And if you don't learn them at that time, it's hard to do afterwards. When a person knows more than one language, different types of pathological conditions can sometimes impact one language more than another. It's often the first language or the strongest language that remains most intact, but that's not always the case, depending on how the brain breaks. So it does make it more complicated. We do the best that we can. When we're looking at a person with a neurodegenerative illness, in this case, what we would do in that kind of a case often is, as long as we were able to test them in English in any case, if that was appropriate at all, we would want to test them after a period of time, after at least a year, maybe 18 months, and see whether they have changed. If they're experiencing a progressive neurodegenerative illness, then there should be some decline after that, after such a period. And so you'd be looking for that. So even if you didn't get their initial level of achievement in language correct, you can see whether they've changed over time, whether according to how they did, they're doing worse now.
One more hook on that, if I'm not delaying anyone else. How about dreaming in a foreign language?
Well, that's interesting. It's an interesting topic in and of itself. It's not usually something that we test. Sometimes people will report their dreams. Dreaming in a different language, I don't think is a symptom of any of these disorders, that I am aware of as a specific sign that a person has a certain type of a disorder. So I'm not sure what else I can say that would be helpful to you.
Thank you very much.
You're very welcome.
Any other questions? If there are no other questions, I'd like to thank Dr. Christodoulou so much for being with us today. Thank you for this wonderful presentation. Thank you all for spending Friday afternoon with us. And if you have any additional questions, I put my email and telephone number in the chat, and please reach out.
Yeah, and please contact us at Stony Brook if you have any questions, if you have any concerns. We have excellent social workers there, who can provide free advice on anything that you might need. So we're there to help, and there to help support your caregivers as well. We just want to be a resource. So thank you so much for letting me.
You work with any
Thank
of,
you. You were excellent.
Thank
Thank
you.
you.
Thank you. I'm sorry,
There was another question.
I was just gonna ask if they work with any of the nursing homes.
Not specifically with the nurse. We don't, we're not specifically associated with any nursing homes. We sometimes see patients from those facilities and a number of assisted livings as well.
Okay.
We're always looking to expand our contacts though. So if you know of one and you want us to hook up with, we'd be happy to hear about that.
Okay.
I'm very, very happy that, the Freeburg JCC and the Center for Excellence in Alzheimer's is working closer together now, and that's wonderful. And we look forward to more presentations with you and your colleagues going forward. So
Thank you. We do
so
too.
much.
Absolutely.
Okay, everyone, have a wonderful weekend. Stay well.
Yes.
Thank you.
All right. Bye-bye.
Dr.
Nice
Bye,
weekend.
everyone.
Dr. Christodoulou,
Yes.
I'm sorry I missed some of your lecture, but I just want to ask you, as far as treatment goes, would you say that metamine helps in preserving some of the memory?
Mementine?
Yes.
Yes. Yes, it's a medicine used for the treatment of Alzheimer's disease, and it's been shown to have some effect on cognition, memory, and general thinking abilities, as well as activities of daily living.
As long as, sorry, I didn't hear, as long as?
I'm sorry, I didn't catch that.
I didn't hear that. You said as long as?
There is evidence for it in Alzheimer's disease. it can be helpful. Yes.
Thank you very much.
You're welcome.
Thank you, everybody.
Thank
Take
you.
care.
All right. Bye-bye.
Thanks. Bye.
Bye-bye.